Hello everybody, and welcome to this exciting conference. The title of the conference today, the lecture today, is the autoinflammatory side of COVID-19, and this event has been sponsored by Novartis with an unrestricted educational grant. And we have a distinguished speaker today, who is Marco Gattorno, who is the leading expert that I guess you all know very well. He's leading expert in the field of autoinflammatory diseases, both in the clinical and research area. He's the chief of the Center for Autoinflammatory Diseases and Immune Deficiency at the Gaslini Hospital in Genova, but most importantly, he is the president of the Eastside. And we also have a young, also well-known speaker who will present the clinical case that will precede the lecture given by Marco, and is Roberta Caorsi. She also works at the Gaslini Hospital in Genoa, Italy, and is a young investigator and clinician who has already gained a lot of experience in autoinflammatory disease, but also in rheumatic diseases in general. So, as I said, the talk of Marco will be preceded by the presentation of a case, clinical case by Roberta, and you all will have the possibility to raise questions at any time, to ask questions at any time during the two talks using the Q&A system. But at the end of the talk, there will be a possibility to open the microphone, perhaps to ask questions directly to the speakers. So now I have finished my duty, and I will give the microphone to Roberta, who will start this very exciting lecture on an interesting topic by presenting us a clinical case. Please, Roberta.
Thank you, Angelo. Good afternoon, everybody. So, as Angelo told you, I am mainly a pediatrician, so I usually see children, and so I'm going to present you a couple of cases of patients we have observed in the last month, and with a question: what is the inflammatory syndrome COVID correlated in children? Is it a Kawasaki disease or it's not? The first case. Sorry, that I have to. Okay. The first case I'm going to present is the case of a boy who is 13 months old, so is a little boy, that came to our unit at the end of March. He is a boy, Caucasian, with a personal and a family history that is not significant. At the end of March, he started to have high fever. He was admitted in a local hospital and treated with antibiotics without any response. And due to his clinical picture, he was referred in our center with the suspicion of a Kawasaki disease. When he was admitted, he had a clear irritability. He had conjunctivitis, cheilitis, an adenopathy that was mainly cervical. He had a macular skin rash and an edema of the extremities, both hands and feet. His blood test revealed a mild increase in the leukocyte count with increased platelet and the presence of a mild inflammation. At that time, a nasal swab for COVID was performed that turned out to be negative. And so, in the suspicion of Kawasaki disease, we started treatment with the immunoglobulins together with high doses of aspirin. And the day after, he had a resolution of the fever. The echocardiography that was performed didn't reveal any finding that was worrying us. The coronae were normal at the time. But a couple of days later, he started to again present fever. And so we performed a second infusion of immunoglobulins and started the steroidal treatment EV with methylprednisolone in 2 doses. These are the exam of the kids when he was admitted. You can see that at the beginning he had increased platelets, mild elevation of acute phase reactants, a normal ferritin, and a normal echocardiography. When he had the reappearance of fever, and so steroidal treatment was started, the echocardiography revealed also the presence of coronary ectasia. He was without the presence of aneurysm, but it was a mild ectasia of both left and right coronary with a zeta score of plus 2.5. But the thing that was rather worrying is that despite the treatment, the kid continued to have fever, continued to have elevation of acute phase reactants, and platelets started to reduce, and ferritin started to increase, even if the value were not so worrying, but the kids continued to have fever. So prednisone was, methylprednisolone was initially increased, but due to the persistence of the fever, we decided to treat him with steroidal pulses of 30 milligrams per kilo every day for 3 days. And just at the 3rd day of pulses, the fever disappeared. And finally, we observed a reduction of acute phase reactants. What rather worrying in that days was 2 things. That the first one is that the platelet were reducing and the ferritin increasing despite the treatment, and that our cardiologist said that the coronary picture was absolutely the same, but they observe the presence of a mild pericardial effusion as well as a mild metallic regurgitation. Luckily, with the treatment, things went right. He quickly improved. So the steroidal treatment was again reduced. Firstly, EV, and then after 7 days, he was treated orally with prednisone. So here you can see that this case is rather consistent with the diagnosis of Kawasaki disease, also because of the age of the kid. He was rather resistant to conventional treatment, but it's not uncommon in Kawasaki disease. But what is then interesting, and that when we had the results of the serology for COVID-19, Francesco turned out to be positive. He had the positive IgG and IgA. Very different is the story of Samuele. Samuele is not 13 months, but he's 13 years old. He's a very healthy boy. He does sports, agonistic sports. His history, family history and personal history absolutely negative. We know that at the end of October, he had fever and mild sinusitis that went to complete resolution in a couple of days without any treatment. But in December, the 10th of December, he started to have fever, and the fever was very high. So he was admitted first to a local hospital and treated with antibiotics without response. He had an important abdominal pain, so they performed an ultrasonography that was normal. But after 4 days, due to the persistence of a very high fever and poor general condition, he was admitted in our hospital. When he was admitted, he had fever very high, and also he complained with both abdominal and thoracic pain. And at the clinical examination, he also had conjunctivitis that was bilateral, cervical adenopathy, and a macular skin rash that was mainly present in the extremities. At that time, the nasal swab for COVID was negative, and in the first day of admission, an echocardiography was performed that revealed a mild dilatation of the left ventricle. the day of admission, what was rather worrying is that he had a reduction of platelet, a reduction of normal leukocyte, but the presence of lymphopenia. He had very increased CRP, and he had an increase of pro-BNP and dimer. We were at that time clearly aware of COVID-19 related inflammatory condition. So at that day, we had the results of the serology that was positive. In the first day of the admission, he was treated with immunoglobulins, but the day after, he was in a very poor clinical condition. He had abdominal pain and diarrhea for the whole night. The blood test revealed again an increase of CRP, and the ferritin that was before for the first time was increased. He had a mild elevation of troponin, and the pro-BNP was increasing. So at that time, we decided to start high doses of steroids, and our hematologist suggested the start of both aspirin and heparin with prophylactic dosage. What was rather worrying is that the day after, even if he was receiving high doses of steroids, he was continuing to have fever. His blood test is more or less the same with, you can see the increase of CRP. Ferritin was more or less the same. Luckily, there was a slight increase of the level of platelet, but the pro-BNP levels were very worrying. And at that time, our cardiologist said that his heart condition were getting worse because he had the presence of dilatation, but there was as well a reduction of the ejection fraction of the heart and the presence of a tricuspid and mitral regurgitation. So according to the evaluation, the cardiologic picture was consistent with the myocarditis. So since he was still receiving high doses of steroids, we decided to go on with the high doses of steroids, but to add the treatment with anakinra. He was treated with 4 milligrams per kilo a day in 2 different doses. And luckily, the day after, he didn't have any more fever. Finally, he started to have a reduction of CRP. Platelet didn't change. More or less, the pro-BNP levels were the same. And so we were at that time a bit relieved by his improvement. He didn't have any more diarrhea and he felt better. But what was important is that he started to have an important bradycardia, that he during the night he had 40 pulses per minute, and he had an increase of the QT interval. But since the inflammation was going rather well, we decided to go on with the same treatment. So he received 3 days of pulses, and then due to the severity of the clinical picture, we decided to give him, he's 35 kilos, so he's not a small boy. We decided to give him another 2 days of high doses of methylprednisolone that were 500 milligrams together again with anakinra. And luckily, things went better, and he could progressively reduce steroid treatment. And you can see that he moved to methylprednisolone 3 milligrams kilo a day. And then in the following days, we could reduce also treatment with anakinra that was withdrawn at the beginning of January. And then steroid treatment was moved to oral, and then he has been discharged a few days ago. The heart condition has progressively improved. The QT interval that was rather worrying during this day now is normal. And in the cardiac MRI, there's still the presence of myocardial inflammation. That is not rather important, but for sure by now the kid cannot do any sports. That for him is rather annoying, but for our cardiologist is essential for his well-being. So this case is very different from the other one, but with different ages of the kids, but with a clear origin that is the same in the two cases. Thank you.
Okay, thank you very much, Roberta. Now, Marco, please.
Yes. Okay. Thank you very much, Angelo, for the very kind introduction. Thank you, everybody, to be here. Thank you, Roberta, for the very good cases that we can discuss all together. I have to say that when we decided the title of the webinar some months ago, we thought that maybe there was more clearness on this aspect of inflammation and COVID-19, and also how to treat them, and we were a little bit more optimistic. So I have to apologize because there is still a lot of unknown, and for sure this presentation is in comparison to the other presentation of the webinar that were a little bit educational in the aim. This is not educational at all, I have to say, because it's really related to my very personal view of what I think could be the role of autoinflammation in COVID-19. So I apologize since now for the two things, that we are all pediatricians, so we do not follow directly patient with pneumonia, but just patient with MIS-C. And also, of course, again, that this is a very relevant point of view from my side, and it would be nice maybe to discuss all together, even of the wrong things and the wrong perspective that I present you today is highly possible. I will say that I will start with this picture that you already seen several times, I see, because this was the shocking evidence from China in the first cases, a series presented with COVID-19, and was quite interesting to see, as you know very well, that there was two different kind of patients, the survival and non-survival, and was quite interesting for us to see indeed that those patients that progress towards death, ECU admission, RDS, ECU admission, and then death, have an incredible situation that was very, very consistent to what we observe in autoinflammatory condition in adult and in children, with a huge elevation of some parameters such as serum ferritin, D-dimer, and some cytokines such as IL-6 that are really pertinent to what we observe in a cytokine storm. That was the reason why, together with a number of friends and colleagues in Italy and in the US, mainly pediatric rheumatology, we start to ask why pediatric rheumatologists and people in a way dealing with autoinflammatory disease, even in pediatric age, should in a way be interested to COVID-19. At that time was just the pneumonia related to COVID-19, and MIS-C was not present at all. So we try to explain that indeed this was really similar to what we observed, and so we make some thoughts. And of course, it's very well known what happens in the different phases and stages of the diseases. And I try to make a sort of summary, and you know very well that the first phase for sure is the type 1 interferon antiviral response that is triggered by the infection of the virus. This is pretty clear. And of course, which is the actual role of type 1 interferon? Of course, it could be the good guy, because of course type 1 interferon has a potent antiviral effect, and so in the normal condition should be clear the virus. But in respect to the COVID-19, we will have two different possibilities, and of course I'm talking about on the perspective of a doctor that is dealing with autoinflammation, an exaggerated interferon response leading to tissue damage, so could be the bad. And we have, as you know, some models of inherited interferonopathies like SARI and COPA that are linked to a severe lung involvement that is related to an overactivation of interferon. But on the other way, there could be also the possibility of an inadequate interferon response, the ugly, that leads to a lack of viral clearance. That, of course, was at the beginning the two possibilities. I have to say that several studies so far have pointed out that the second possibility, so a lack of interferon activity, has a very probable cause in the very severe cases. This is the paper coming from the group in Paris that show indeed that, as you know very well, that patients with the very critical and severe forms have a lower interferon score, a lower level of interferon, and also a lower level of interferon activity in respect to the patient with a mild or moderate disease. Of course, we have to ask if the timing of the evaluation in this patient, in these groups of patients, were the same. And of course, this is the main question in the interpretation of this data. But however, there was other data. You know, I think very well what came out from the study, very large study of the group of Jean-Laurent Casanova. Of course, was clear that a possibility could be that some patient, especially the more severe patient, maybe those that have in a young age a very severe diseases, could be affected by carrier variant of genes that are very important for the defense against viruses. And so they study 13 influenza susceptibility loci, and they found that indeed an enrichment of loss of function variant in patients with a critical COVID-19. And however, that was interesting. There was a number of patients that, 4 patients that had even two variant of genes that are related to the response to influenza. And the experimental deleterious allele in this study account for, however, just 3.5% of the world population. That was studies that was more than 600 patients. Another very interesting study, again pertinent to the role of the type 1 interferon, was the identification from the same group of a high number of patients with the critical COVID-19 with the sera positive for autoantibodies to type 1 interferon. You know, this is a possibility that during the inflammation that some autoantibodies can, let's say, be produced and be in a way linked to a down modulation of the interferon because of the presence of autoantibodies that were present only in patients with the critical situation and not in the patient with asymptomatic or mild infection. And again, type 1 interferon was lower in those patients with antibodies. Again, that could be also related to a different concept, a different magnitude of the immune response in patients with autoantibodies with more severe clinical condition in respect to the milder, but this is a very interesting issue. However, it's possible then that a lack of clearance can provoke the persistence of the virus and damage and recruitment of cells of innate immunity. But however, it's still, in my opinion, still a little bit mysterious, which is the link between the type 1 interferon antiviral response and the cytokine storm. It's just a lack of effect of the type 1 interferon, or maybe there is also a role of type 1 interferon in the beginning, in starting the pro-inflammatory activation of also other cells of innate immunity, monocyte, macrophage, and so on. Indeed, for the production of DAMPs, pro-inflammatory cytokines, and other stuff. For sure, this is possible because maybe DAMPs from immune and dying endothelial cells can activate the monocytes and macrophage, cells of innate immunity, and maybe also viruses. So part of the viruses can act as pump, and they start the activation of the cells of innate immunity and the so-called cytokine storm that we know very well. You know, of course, that the tissue is full, is really, let's say, infiltrated by macrophage, beside also memory T cells and in the lung, and that is, of course, the cause of the severe inflammation in the lung. I'm just talking about the inflammatory aspect and none of the thrombotic aspect, as you know, are really pertinent and really important in the disease. I try to focus just on the inflammatory response. Another important issue you know was how to deal with steroids. That was at the beginning a big issue. I have to say that that statement that was at the beginning very well followed, not to use steroids, was something that alarmed all the rheumatologists, pediatric rheumatologists, or people dealing with cytokine storms, because, as you know, steroids is the drug of choice in this kind of treatment. There was some editorial that did not support the use of steroids, and also the interpretation of some papers was in a way misleading. For example, in this very famous cohort, there was a patient that the patient that survived had, let's say, less number of patients treated with steroid. That was much more treated in the more severe patients, and was significant. That could be, let's say, interpreted like a confounding aggravation of the disease. And but also another important point was the timeline in which these patients were treated with steroids. You can see here from here and from here at day 13 and 12, and you can see here, when you see the dynamic of the inflammatory markers that are here and here, you can see that it was very late during the inflammatory process. If we start treating a cytokine storm in a macrophage activation syndrome, we know that we do not have to start steroid here, but I have to say that we have to start here when the cytokine storms start. So there was a lot of struggling to say steroids should be used, as you know very well, and I think all the hospitals start to have internal protocol in which steroid in a way was hallowed. Thanks God, we had this preliminary, the first data coming from the recovery study that showed that indeed dexamethasone in severe patients with invasive mechanical ventilation, at least in this trial, were really effective. That was, of course, a very important step to start the use of steroids of many patients. As you know, Another important aspect of cells and related to cytokine storms and mostly related to what happened in the cytokine storms after CAR T cell therapy was related to the possibility to use tocilizumab in these patients. Especially when the steroid was in a way avoided, and there was the first reports from China on the possible use in some very rather small study with a good reports. And as you know, in Italy and then in France and then in all the countries that little by little in the Western country were affected by the pandemic, and unfortunately, there was several reports, observational study, especially done in single hospital, showing indeed the actual benefit of tocilizumab in the patient, especially in comparison to with in respect to patient not treated with anti-cytokine treatment, but just to standard of care. The use of tocilizumab, as you know, at least in Italy, but I think also in other countries, was so impressive at that time that there was a lack of tocilizumab around Italy, and I think in other countries. And of course, there was a lot of ideas on how to use different other drugs to start to counteract the cytokine storms. And IL-1, as you know, as doctors that are dealing with macrophage activation syndrome and cytokine storms, is for sure a potent possible therapeutic tool. We discussed a lot with our colleague. We did not have already any patient with COVID-19 related hyperinflammation in our children hospital in Galzini Hospital, but there was a lot, of course, in adult hospital, COVID hospital in Genoa, that was together with Lombardy and Piedmont, the first region of Italy that has been hit by the pandemic. And since they were really, we had a lot of difficulties in treating this patient, we suggest to use a high dose of anakinra in this patient. Not only us, but other hospitals, as you know, start to use high dose anakinra without steroid with a rather good response in a few days. What we suggested was to do very early, and as soon as the patient were severely affected and very ill with a severe pneumonia, we suggest, of course, to start high dose intravenous anakinra, and that was indeed with a good results. That was a pilot study that we performed, and in our hospital and also in other hospital in Europe, there was several other similar study that was observational study. I mean, in which the patients were treated with different regimen, with IL-1 blockers, with or without steroids. In this large population, and this is a paper that is now close to the final evaluation, we treated a number of patients with this concept of a very early onset autoinflammatory disease as soon as they arrive in the hospital with a very severe pneumonia. And half of these patients were treated with anakinra alone, and half of the patients were treated with anakinra, high dose of anakinra, and methylprednisolone. Because these patients arrived in the first aid department, start methylprednisolone because anakinra was not immediately available, and then they start anakinra 1 or 2 days after. Other can start anakinra just at the beginning. And we compare this patient with a number of patients in the same period that do not receive an early anti-inflammatory treatment, some patients with standard care only, and some other patients that receive a late anti-inflammatory treatment during admission in ECU and after many days after admission. Our idea was to see if there was a difference in the treatment, very early treatment in severe patients rather in the late treatment. And the statistical analysis of this patient and this cohort of patients is absolutely difficult, and you know how many variabilities, especially, and how many bias could be present in such studies, and how difficult is the evaluation of the baseline characteristic of this patient that could be rather variable. After, of course, a proper statistical analysis that was balanced, we understood indeed that the early anti-inflammatory treatment was able to prevent in a significant way the progression to death in the majority of patients. And there was not a difference in this study between the use of anakinra alone in respect to anakinra plus glucocorticoid. You can see here the development of acute phase reactants soon after the admission in respect to controls with a standard of care. And here is just the evidence of the response in patients that have a good response, in which we have a amelioration of respiratory parameters and also of amelioration of the respiratory assistant. And we could not find any substantial difference in the responders between patients that have anakinra plus steroid in respect to anakinra alone. The only difference was in a faster reduction of CRP. You can see here, this is day 0 when they started treatment, when they were treated with anakinra and steroid. So that was one of the multiple studies that came out in the last months from several hospitals that show all with this kind of observational study, retrospective study, that had a lot of limitation. But however, more than 350 patients has been now described to this kind of study, all with a rather important amelioration in terms. However, there are a lot of limitations related to the changes, as you know, of the severity and also of the management of the disease, even during the first week of the pandemic, that can influence a lot the result. A little digression why IL-1 is involved. This is, and mainly is it involved? What came out and raised our attention since the beginning was this paper that came out in 2019 from this group. They was not pertinent to COVID-19, but was very interesting because it was showing that one of the possible reasons why bats does not die of SARS or viral infection, and they represent a fantastic reservoir for many, many viruses. Indeed, these animals do not have the machinery and they do not respond properly to the classical stimuli of that activate the NLRP3 inflammasome, and this is one of the reasons why these animals do not develop a huge inflammatory reaction after the exposure to SARS-CoV. Stefano Volpi in our lab started to study with all the group. We study since many years the pattern of IL-1 secretion in patients with autoinflammatory disease. But in the meanwhile, also some other groups start to produce some evidence on indeed the role of IL-1 in COVID-19. This is a very interesting Brazilian study from Brazil, São Paulo, in which they show that indeed the infection with SARS-CoV-2 is able to trigger IL-1 secretion and NLRP3 inflammation. You can see the prime cells that has been increased elevation of secretion of IL-1. These patients have also elevated level of active caspase-1 and IL-10 in circulation, and also evidence of activation of caspase-1 in the monocytes. And also, what is quite interesting, also even the inflammatory infiltrate of anti-CD4 cells, let's say, is related and is associated with a clear overexpression of NLRP3. So this paper, of course, is important because it gives the first evidence of the actual role of IL-1 and also the direct possibility of the virus to infect and to stimulate IL-1. What we did in our lab was to study, as usual, like we did in cryopyrinopathies, the pattern of secretion of IL-1 from cells of severely affected COVID-19 patient. And what was quite interesting to see that in respect to the normal situation in a normal individual, the patient with COVID-19, some patients have a strange secretion of IL-1 even despite any stimulation. You can see here that was controlled by the inhibition with a specific NLRP3 inhibition. And that was also the case for IL-18 with the same spontaneous secretion without stimulation of these cells. That is something very strange that we usually do not observe even in patients with cryopyrinopathies. You should have at least one signal in patients with cryopyrinopathies to have a secretion of IL-1. And that was not the case for other cytokines such as IL-6 and TNF. As you know very well, that the normal response and activation of IL-1, the NLRP3 inflammasome usually need two signals, and what you can see is the secretion of IL-1, but also the formation of the ASC spec that are, let's say, the evidence of the activation of NLRP3 inflammasome in the monocytes of the patient. And what we observe, indeed, even with cytofluorimetric analysis and analysis of the formation in monocytes of patients of SPEC. You can see here in patient unstimulated monocytes from ASC. You can see normally this is the ASC NLRP3, and this is what happens in COVID-19 patient, the formation of ASC even without any stimulant. So there is something that activates the inflammasome and during the viral infection that is completely different from what we observe in the normal autoinflammatory diseases, and using IL-1 blockers, in this case, we can down-modulate this secretion. So is there any link with SARS-CoV-2 and IL-1 secretion, which is the mechanism? Unfortunately, we have worked a lot on this. Unfortunately, and we think that we have one of the possible mechanisms that link the presence of the virus with the activation of NLRP3. Unfortunately, this is still, we still have to I cannot share so far our final aim, but I hope that very, very soon we will be able to provide the evidence of the possible link between the viral infection and the mechanism of activation of the NLRP3. This was very nice, in my opinion, very interesting, but however, what came out from the evidence from the clinical trials, of course, that are the most important evidence, were really disappointing, really disappointing. Very recently, the first result, at least with tocilizumab, came out, and this is a paper came out some 1 month ago. And indeed, it was clear that tocilizumab was not able to have an impact on the progression towards mechanical ventilation and death. There are very few events, and you can see here, especially in comparison to what was observed in the first months of the pandemic, there was, and the high mortality and progression towards ECU in the first observational study in the different hospital. These events were really rare in this study. We have to understand that these patients were non-ECU hospital, that 80% have just a very mild respiratory manifestation, that they have just some oxygen by nasal cannula. 16% were not receiving supplemental oxygen at baseline. Another important issue is that the median age was rather low in this patient. Of course, this is not the age that usually go towards a very bad progression. And it's the same was for another study that was published 1 month in November, and was another study that was stopped because of inefficacy in Italy. And we have the same situation, no difference in tocilizumab and standard of care. But again, was quite surprising, knowing the impact of the disease in the first months of the disease, the very low number of admission in ECU and death, not only in tocilizumab patients, but what was quite striking in the group using standard of care. Just 1 death and 5 patients arriving to ECU. And of course, with this data, it was not possible to show any difference, and the trial was in a way failed. Of course, there are many difficulties in designing in such a short time a proper trial. I think it was really a fantastic thing, try to make very early a trial design, but I also think that was very difficult to make the right design. If you think, at least in Europe, most of the trial were designed with tocilizumab, but also some trials with anakinra that has not been published so far. We know about the interruption of some trial, even both with tocilizumab and anakinra, but unfortunately we do not have still the data to see and to understand in a way what happened. But was interesting to see that despite beside the severity of the disease, that there also the moment, of course, they were planning in this period the trials, and at least, for example, the trial in Italy was performed in this period, in which the epidemiological presence was, and the number of severe cases, the number of cases, the number of severe cases were completely different in respect to the time in which the trial were designed. I finish my presentation with the part more pertinent to the pediatricians, and that was the second reason we should be alerted. Roberta presented very well two cases of multisystemic inflammatory syndrome in children related to COVID-19, and this is in a way a representation of the manifestation that you know very well, that are really huge in terms of severity, and also of the different organs and systems that can be affected, and the presence of myocarditis that is and the shock that is of course one of the most worrisome and severe manifestation. It's clear that this is a disease that is related to a delayed hyperinflammation, as we know, there was the clear sign in Bergamo, the first city in northern Italy, and the first city, of course, in Western Europe, that observed a huge increment of the cases of Kawasaki disease in their paper 1 month after the outbreak of the pandemic that was, as you remember, for sure, dramatic in Bergamo 1 month after, and that the same was in other countries, as you know. We all think that the children have a milder infection, respiratory infection, may be related to a lack or reduction of ACE2 receptors, the target of the virus, and then they develop during the time a delayed hyperinflammation. There is a lot of discussion. I don't enter in this discussion. Is rather interesting, and I'm very happy that Angelo is here, because maybe we can discuss on the similarities and the differences between Kawasaki and MIS-C. Also the fact that there is a part of Kawasaki disease that is very similar to MIS-C, the Kawasaki disease shock syndrome. And however, what is clear, these are data that are related to the Italian population, was already presented by Angelo and our colleague at ACR, the Italian, the first, let's say the cohort of patients in the first wave in Italy with this condition. And you can see here that the prevalence in Italy were related to patients that had a clear-cut Kawasaki disease, and there was at that time less patients with a much more MIS-C-like phenotype. And so they compare the two groups. And of course, as you know very well, the age was different, and we know that age is a very important factor. The other Kawasaki manifestations were not that different among the two groups, maybe higher coronary artery abnormalities in the, let's say, Kawasaki group. And in the other way, the MIS-C feature, of course, were prevalent in the MIS-C, but were also present in the Kawasaki disease with diarrhea, vomiting, and abdominal pain. Many patients with myocarditis, as you know, and many patients with shock. The typical examination that Roberto already showed you in this very severe patient, and the use of high amount of steroids and anakinra. This is the typical aspect in which we treat this patient. Is for sure we are much more aggressive, as you understood, with high dose metoprolol bolus and anakinra or other anti-cytokine treatment afterwards in patients that do respond. What is relevant? Of course, this is not the same in all countries. There are many factors that are related to the mortality in children, but at least in Italy, even in severe cases like Roberta showed, fortunately, we do not have any death. And I think that the attitude in treating this patient rather aggressively, of course, is completely different. There are no comorbidities, and there is no important lung involvement in this patient. That, of course, is very relevant in adults. But however, we can discuss on the fact that an aggressive anti-inflammatory treatment maybe can play a role in the good outcome of this condition. Just to say to you, to finish, that there is an international registry on COVID-19 in Europe. The START is let's say, a combined action of different society, ISAID, but also ASID and PRESS with Printo, and under umbrella of ERNA-RITA, that indeed try to make a registry, common registry on this disease, not country by country. We have a lot of a paper coming from the different country, but try to make a sort of global registry. And if you are interested, of course, you you can contact Printo to participate. So in conclusion, COVID-19 pneumonia is still largely a mystery. Why only a small percentage display a more aggressive form and eventually die? Of course, this is the question that everybody is asking for. We know, and as an expert, let's say in inflammation, that there is a critical role of cells and cytokines in innate immunity in the cytokine storms. There is indeed the need to understand which is the link between the first phase and then the activation of macrophage in some individual. We think that beside IL-6, also IL-1 play an important role in the cytokine storms. How does SARS-CoV-2 play a role in NLRP3 activation? Does it or not? In which way? This is something that will be really important to understand and in the next future. And anti-cytokine treatment has been used a lot in the first phase. We have to think all together and evaluate very well the limitation and the good things coming from the individual study in different hospital, retrospective study with all their limitation, but also take into account carefully what really the trials so far are telling to us. Is it possible that there is still, also taking into consideration the very high mortality that we still unfortunately have with this disease, there is still a role for anti-cytokine treatment? In which subpopulation? Which is the correct treatment? Are we aggressive now with patients that have severe cytokine storms? For sure, also in the condition, we need a treat-to-target approach that we are very familiar to. And what about MIS-C? Of course, this is a new and potential lethal disease, and aggressive anti-inflammatory treatment seems to help in the management. So this is, I really apologize if I said a lot of wrong and misleading things. This is open to discussion, and I'm not sure or anything. I am sure that I want to thank all the people working in my group, in my lab, Stefano Volpi, that coordinating with the help also of Anna Rubartelli, that is working with us as a consultant, and all the people in the lab working with us on autoinflammatory diseases and also on IL-1, the people in the world that are dealing with the patient. And finally, I want just to, as a president of ISAID, to remember you this new appointment. The next year we will not have the formal meeting. It will not be a meeting but we will have a meeting. It will not be in 2-3 days, but will be a periodic congress. Of course, as a society of autoinflammatory disease, we could not do anything rather but a periodic congress. So there will be meetings in which the session will be spread during the year. We will find in our website a program very soon, and I think it will be very interesting, very interactive. We will try to do, and not too long, just 2-3 hours of a session twice a month. So thank you very much for your attention.
So thank you very much, Marco and Roberta, of course, once more. It was indeed a very exciting and provocative talk, which provided us with many new and very updated data, but also emphasized the open issues and unmet, let's say, problems that still exist in the interpretation of this of some of these COVID-19 related illnesses. So it's as a general comment, I would say that as president of press, that I'm not much surprised that a society such as Eastside, which takes care of periodic fevers, organizes periodic congresses. This is very much in line with the characteristic of the diseases that you take care of. So there are already some questions through the chat. I remember you that you can address questions to the speakers this way, or perhaps in the end we can even open the microphone, allowing you to address questions directly with your voice. So there is a question from Anna Sediva. This is for Roberta mostly. So thanks for presenting this disease. I'm wondering how to explain high sedimentation rate and low CRP in the first case, and also to some extent in the second case. Is there explanation, Roberta, for this discrepancy?
Yes, there is, but we don't have. It was rather strange that in the first patient that he had the clinical picture that was fully consistent with the Kawasaki disease. That the only thing that was rather atypical is that he had just a slight increase of CRP at the beginning, and then he had an increase, but it was not so important as we are usually used to. So yes, it's what we have observed, and it's rather strange in that case. I have to say that it was one of the 6 cases that we observed in the first wave, so in March and April. And at that time we observed mainly very young kids, so they was all younger than 2 years old, and they all had a clinical picture consistent with Kawasaki disease, and he was the most atypical, with also the presence of a worsening after the beginning of the treatment. So yes, I don't have an explanation about ESR in that patient.
Anna, do you want to comment?
Yeah, if I can add something,
yeah, sure.
In a patient, in a patient who already received the intravenous immunoglobulins, it can be that ESR might be increased due to the effect of this load of intravenous immunoglobulin, which might affect the viscosity of the plasma. But I don't remember if this feature was seen after administration of EIG or already at the onset of the condition.
In the second patient is more clear because he had an increase after immunoglobulins. In the first one, he still have high ESR at the beginning of the story that was higher than CRP, but it increased, of course, in the days following the infusion.
Okay.
You know, if I can, I was wondering about autoantibodies against IL-6 or something like that, because it can cause the lower CRP, and it's very typical for these children to have some autoimmunity.
Yeah,
that's
very good.
Another interesting explanation. Yeah.
Thank you, Anna. Yeah.
So thank you very much. So there is another question from Catherine Dean. So it's more on interferonopathies. So my daughter has a mutation of PSMB8, assumed Kendall syndrome variant. So she receives 400 milligrams salmeterol monthly, IVIG, and baricitinib. Mm-hmm. So the baseline high type 1 interferon and extensive myositis. She had baseline this kind of feature. So the question is, could her, in this background, could her monthly medicine regimen protect her from the serious side effects of COVID, as some of these treatments are also the treatment for the cytokine storm COVID can bring on?
Of course, this is a very, very interesting question. Of course, we think that in a way the treatment that we do could be protective for cytokine storms. I have to say that it's not clear the role of steroid. Indeed, there are some diseases, for example, multiple sclerosis, in which some data show that people that are, let's say, receiving a high dose of steroid are more at risk to develop a severe infection. Not for the other condition, maybe to other drugs, like, for example, rituximab, that can be, let's say, linked to a more severe. So this is not the same for all the drug. However, it's interesting also the point on JAK inhibitors, because indeed, this is in a way in contrast with the idea of a lack of interferon response that can lead to more severe and aggressive course. It's strange. It's very, very peculiar that indeed even JAK inhibitors can have a good effect in blocking the cytokine storms. It's not completely strange if we think that, as you know very well, JAK1, JAK2 inhibitors are not blocking just the interferon pathway, but many other cytokines, including IL-6. So the level of action of JAK inhibitors is wider than just anti-interferon effect.
So another interesting question from intriguing also and challenging question from Sefi Uziel. Any thought or guess for possible delayed hyperinflammation following the vaccines? So do vaccines potentially lead to raise hyperinflammation? Marco.
Hi, Joseph. Sefi, is a pleasure to meet you. And Sefi is an expert in vaccine and is dealing with the working group on vaccination in press. And it's important, and we have to understand what will happen. I think to some diseases like hyper-IgD, mevalonate kinase deficiency, what we are facing. Sefi, today we discussed with Phil Hawkins. Maybe Phil is around here because he's attend on how to do with hyper-IgD patient, and Phil is here. And if you want to intervene, I think it's important because we still have to understand. Indeed, especially with the RNA, maybe we introduce a pump in some diseases like, for example, MKD, we can exacerbate a flare. That could be a possibility. We have to balance. You are vaccinating a lot in Israel. You have the record of vaccination. I guess that many individuals with FMF has been vaccinated. I will ask you, to both of you, what is happening? Are they reacting?
Hi.
Whatever. Maybe Sefi and then Phil.
You know,
yes.
We don't know yet. Probably I don't think we see like post-vaccination hyperinflammation syndromes. I'm not aware of this. Still, the post corona hyperinflammation is mainly in children, and we don't vaccinate children so far. We also, until now, we vaccinate also the older people above 60. So I'm not aware that there were any late hyperinflammation till now, but we will get the data. So.
Yeah.
I can just say that after the second vaccine, and I think Israel is leading the world in people who've undergone the second vaccine, there are quite a few inflammatory reactions, fever and chills and fatigue, and I wonder what would be in the autoinflammatory patients. I don't know yet. It's also possible that it's vaccine dependent. It could be that the mRNA vaccines, which are given in Israel right now, are more immunogenic than perhaps other vaccines. So we still need to see. I did ask my adult colleagues, I didn't receive an answer yet, about FMF patients.
Of course, this is particularly relevant for autoinflammatory patients with autoinflammatory disease, but also for patients with autoimmune disease or rheumatic condition. Angelo, so far the recommendation in the EULAR and so on is to vaccine patients with rheumatic condition.
Yeah, but you know, so far, I don't know in Israel, but in Italy at least, we don't have any experience with vaccination in children. As far as I know, no individuals younger than 16 years has ever been vaccinated in Italy so far. So we don't know yet if these vaccines could elicit this hyperinflammatory disease like MIS-C? This is a very difficult question we can't answer, at least with Italian, based on the Italian experience.
This
Okay.
should be a subject of a trial, I have to say.
Yeah, of course. There should be a very careful surveillance of these events. Anyway, so thank you very much to our friends from Israel. So there is now Leonardo Oliveira Mendonca. He just congratulate.
Very kind,
Roberta is very kind of him. Thank you very much. I agree and share your appreciation as moderator. Cristina Iannuccelli, in Italian name and surname, it looks like. Good afternoon. What is your experience of SARS-CoV-2 infection in young patients with autoinflammatory diseases? Thank you.
This is a very important question. As you know, Christina, we were rather afraid at the beginning that especially patients with autoinflammatory disease with the tendency of overreact to stimuli, they could present more severe infection and hyperinflammation. I have to say that if I'm not wrong, please, Angelo, correct me. I don't think that there are patients, or very few patients with MIS-C that has a previous history of autoinflammatory disease, I'm pretty sure, but even of rheumatic condition. So I think these are extremely rare in the World Series.
Yeah, what is I agree, Marco. I'm not aware of any case of a MIS-C which occurred in a child with previous rheumatic autoimmunity, with one exception. There are 2 cases out of 28 seen in initial experience in I think in the Boston Children's Hospital, who previously had Kawasaki. Few years before they had classic Kawasaki disease, and recently they developed MIS-C. So this in some way supports the idea of a common genetic background and a common a similarity also in the pathogenesis of these 2 conditions. But there are few cases. So
if I can add, there is also this very interesting study from France. They study, I think, 350 FMS patients that were infected, and the outcome was really good. Just very few patients have a very severe outcome, and those had a number of comorbidities or were pretty old. So in that paper, the first paper, I don't know if you are aware of others, but was the first that analyzed for the first time the impact of COVID-19 in the population of patients with an autoinflammatory disease, and the first results are really reassuring so far.
Okay, then there is Anna Michaela Balanutta. She sends her congratulations. Okay, very good, thank you. So there is anonymous attendee. Then we should guess the name based on the question. So how do we choose the anti-cytokine strategy among different biological agents? Is there a priority option according to the organ involvement?
My God. So Roberto, do you want to comment? With the microphone on?
Microphone, Roberta. You are silent.
There was a reason why I'm silent. Well, in MIS-C, well, I have the impression that is the main therapeutic approach of MIS-C is steroids. I don't think that without high doses of steroids we go anywhere. So my first answer is try it with steroids, with high doses of steroids. What we have, our sensation is that being such an inflammatory condition and being so how can I say, confident in the use of anakinra, being a drug that is rather easy to use with a short half-life, and being this difficult patient to deal with because they can also have a severe infection. We think that anakinra may be the first choice because of that, but I have to say that we had, by now, our experience was good with steroids, and we used anakinra just in a couple of patients, and they went very good. I have difficulties in thinking to change the biologic approach according to the presence or not of other organ involvement, as I don't know, bowel or so on in MISC.
Yes, if I can add just one point, I agree with Roberta 100%. There is only one exception, perhaps, if there is liver involvement because I have read some experience on that. If there is liver involvement, anakinra can be in some way contraindicated. And I have read that some of these patients with increased transaminases, which is rare, of course, these were given instead of anakinra. Infliximab with good results, but this is a few cases. I mean, children with MIS-C. Yeah. Okay, thank you very much, Roberta. So there is now another question by Rinat Raupov. The questions are increasing. How long should we use prednisone and aspirin in patients with PIMS-TS? Maybe Roberta, you should answer this question. How long?
How long? For sure, steroids, you have to, we think that you have to keep with high doses as soon as the situation gets improved. When the situation gets improved, usually the children start to feel better, and the inflammatory markers as well as the cardiac enzyme tends to decrease. And so according to that, you can start to decrease. We usually move to oral treatment when they have normal CRP and start to reduce anakinra. In the two cases that we were treating with anakinra, we started to reduce anakinra when they have had a good control of the clinical manifestation, persistent absence of fever. And that patient were receiving subcutaneous anakinra, so they prefer before interrupt anakinra and then reduce steroids. But in any case, the impression is that you have to keep high doses as soon as the situation is not changing his curve, because as the thing that is rather similar to Kawasaki disease is that in most of the cases, this disease starts, have its peak, and then if you treat it in the right way, slowly it improves. It's rather uncommon. We have seen a couple of times that there is a rebound of the disease. So when you have achieved the good control, you can start to decrease and then move to oral treatment. I have to say that usually we move to oral steroids when they have a complete normalization of CRP, and then according to the cardiac situation and general condition, the reduction of steroid up to the withdrawal usually lasts 1 month, 1.5 months after steroids are taken by orally.
Rinat, any comment? Do you want to comment or to?
No, thank you very much. Do you hear me?
Yes.
Yes.
Sure.
Yeah, okay, because I have a patient with carditis, and now he's stable, and he's taking oral prednisone, 1.5 milligram per kilogram, and I don't know, okay, how fast should I taper the dose and how long should I use prednisone, because I'm afraid a little bit that flare come back.
Keep calm.
Yeah.
But if it's classic MIS-C, usually when these children recover, flares are quite uncommon. You know, it usually takes 2-3 weeks maybe a little bit more in more severe cases, but as soon as they go into remission, they rarely flare. It's like Kawasaki disease, the course in some way.
Okay, and how long should we use aspirin in these cases?
Roberta, aspirin.
Antiplatelet aspirin.
Yes.
Usually we are driven by cardiologists and hematologists that choose, but as in Kawasaki disease, usually they prefer to go on for up to the complete normalization of both ESR and CRP, and with up to the normalization of the cardiac ultrasound. More or less in our patient was like in Kawasaki disease, 8-10 weeks.
Okay, so two quick questions for Roberta. So does the level of D-dimer differs between classic Kawasaki disease and post-COVID KD or MIS-C?
Well, I have to say that we were not very focused on the dimer before MIS-C, because we were not quite used to see elevated dimer in Kawasaki disease. I have to say that in children, in the children of the first wave, we just have in a couple of patients a mild increase of dimer, and they, as I told you, they were younger patients that with the clinical picture that was consistent with Kawasaki disease. While in the patient with of the second wave that are older, the youngest of them is 9 years old, they have a disease that is more severe with a different cardiac involvement, because they have mainly myocarditis and they have an increase of dimer. And that's why we usually in this patient, our hematologist suggests also the use of heparin, because they tend to have an alteration in the coagulation. So it's important to be sure to avoid the presence of thrombi as well. So yes, we for sure in the older patient and in the patient with the more severe phenotype, there is an increase of dimer that is not rather uncommon in the younger and uncommon in classic Kawasaki disease.
Okay, second question from Turkey, from Huri Ozdogan. Hello, Huri. Thank you very much. So, thank you for the excellent talk, she says. What was the maximum daily dose of anakinra intravenously that you use in these cases, Roberta? Intravenous.
We didn't. I have to say that we started with subcutaneous anakinra in both cases. There was 4 milligrams per kilo day, and they did well. So we didn't treat them with EV anakinra. I know that in the COVID adult patient, I give them up to 600 milligram EV a day. Marco, if I'm not wrong.
Even yes, usually they can usually 400, but sometimes they arrive at up to 600 milligram in 24 hours. I have to say also that also very high dose of canakinumab has been tried. We didn't focus on canakinumab, but there was recently there was published a retrospective paper on the usefulness of canakinumab in Italy. But again, this is another drug in which we had an interruption of a trial because of
lack
of efficacy.
Okay. Okay, thank you very much. So, see, I've read also in the US literature, they have raised anakinra up to 400 usually, 10 4 times a day. Sorry, 100 4 times a day, exceptionally to 600 or 800, but really in a few cases. The regular dose is, the most severe cases, is 100 every 6 hours.
Yeah, at the beginning, the people was a little bit scared on the use of anakinra intravenously, but you know that anakinra was done to be given intravenously for sepsis and other, and the first trial were very high doses intravenously to react to the sepsis. So it's a safe drug used.
Okay. Thank you, Marco. So is a question for Miriam Nunez. Thank you, Dr. Gattorno. Excellent as always. But there is also a question. It is true that the early treatment of hyperinflammation is the key to proper evolution. In Mexico, 211 children have died from COVID infection.
Miriam, do you want to comment?
The majority from severe ARDS and co-infection.
Do you want to comment? The possible reason, Miriam, is the delay in referral. What do you think? If you want to comment,
you can open your microphone and
yes.
And provide us with your experience, because really impressive.
Really
211.
Miriam?
Hello?
Hello.
Can you hear me?
Yes,
Yeah,
very well.
Hi, Professor. How are you? I'm so happy to see you again.
Me too.
Well, and in Mexico, I'm not treat directly these patients, but we are gaining experience in this area. And there's an interesting study in hospital in Mexico that was published one month ago, and these patients was underlying other conditions such oncohematological, like leukemia, and co-infection was the reason of that. In our hospital, I work in Guadalajara. We don't treat these patients directly because the evolution is good, and we don't have that children's yet. But
okay.
This study is with some patients in hospital in Mexico City.
Okay, we should speed up a little bit because we are running out of time. Thank you very much, Miriam. So there are two positive comments from colleagues from Armenia, and then there are a few other questions. Please, quick answers. So another anonymous attendee asked, I would report that several our patients with FMF treated by colchicine or Kineret did not have hyperinflammation triggered by COVID infection until now.
So that is confirmation so far. Even if you are anonymous, is very important.
We have some with systemic arthritis as well.
We appreciate anyway.
Yes.
Even if it's anonymous. Raquel Faria, hi, thank you so much for the presentation, including adult cohorts in them. So would you consider reasonable in the clinical practice to test for anti-interferon 1 antibodies in severe COVID patients? If positive, how would you treat them? It's a challenging question, Marco. Interferon.
Very, very challenging question, because of course, it would be theoretically interesting, difficult to manage from the practical point of view, of course, and also how would you treat them? If I would ask you, Raquel, how do you treat it if you find anti-interferon antibodies? Which kind of treatment you should use? It should be different from what we use, steroid and so on. I don't think, but I mean, this
difficult
is
to say. Okay, so question from again from Israel, from Phil Ash. We have two kids who developed a limited picture of systemic JIA lasting for little more than 1 month post-COVID. Have you seen this feature? Maybe Roberta, you want to answer?
No, we have seen patients that had the more fully phenotype, but I think that maybe it can be reasonable that can have something like that, because it's a disease that can involve many systems. So I think that also joints can be involved. Our patients, some of them had joints involvement, but together with all the rest. So mucositis, heart involvement, and so on.
So thank you, Roberta. So a question from Ivona. Thank you for these great presentations. So Marco, for Marco, in your monocyte assay, which showed high production of IL-1 in unstimulated cells of COVID patients, is this something also observed in Kawasaki or patient with HLH?
Ivona, as usual, is an important disease.
Of course.
It's an important question. Thank you, Ivona. I don't know. So far, we are, of course, we are studying the same in the MIS-C, and we are analyzing the same response. We didn't do in the classical Kawasaki patient. That will be very interesting to see. We never, and maybe in the future we will do as soon as this pandemic will. I don't know in HLH. I don't know. We never test again patient in active form for secretion of IL-1. This is a very interesting question, Ivona, as usual. We want to comment because we cannot refrain to have Ivona here and say something.
Oh, thank you.
We need to hear your voice, Ivona.
Yes.
Please.
Hello to everyone. Regards from Washington. How are you all doing?
Quite well. I'm surviving so far.
You look great.
Just got the first vaccine shot.
Yes. Yeah.
Well, that's great. That's great. Well, we are still waiting to be called to receive vaccines.
Really?
So yes, so I'm, you know, sort of turning into a hermit working in the basement of my house, waiting for the vaccine to get out from the house. No, I'm joking a little bit. So, but we seem to be a little bit behind the schedule, what's happening in Europe and in some other countries.
Yes.
So, yeah, this is an interesting question to me, because I was just wondering, you know, why do you see such a thing, you know, in cells of these patients? Is it really something specific to this infection, or it just reflects, you know, the hyperinflammatory state of these patients?
We think that that this is rather specific to the stimulant, some stimulant that are pertinent to some portion of the virus. Unfortunately, I cannot say more, but I think that this is rather specific, and there are some potent stimuli that are able to function as signal 1 and signal 2. That is the hypothesis that we are working on.
Well, for that experiment, you need to do additional controls, right?
Sure.
Patients with other infections, or
Right,
possibly patients with
course.
HLH or some other hyperinflammatory state.
Yes.
But that's great.
However, what was striking indeed was the different, you know, that we performed several times in cryopyrinopathies. Even the worst cases of NOMID or SINCA never have this kind of,
Anything like that.
so this is very, very strange.
Yeah, I agree on that. Thank you very much.
Okay, thank you, Ivona. Thank you very much for your contribution. So I think we can take the very last two questions, then we stop. You know, I think we should have stopped at 7, so we are 5 minutes past the time. Anyway, so one interesting question is William Alaid. So he or she thanks. What is your experience in using tocilizumab in MIS-C?
I don't know, Angelo, is there any...
No, I can. If I can comment on this, I can tell you that in the ACR guidelines, the use of tocilizumab in MIS-C is not recommended because it might worsen the pancytopenia on one side, and on the other side, it might even induce liver toxicity. So it's not really is not considered suitable. So IL-1 and on the second line, TNF inhibitors in case of failure of IL-1 inhibitors, TNF blockers, particularly infliximab. And then the last question from Cristina, again, Iannuccelli. Okay, there is also Raffaele Manna, congratulates. Hi, Raffaele, how are you? Ciao. Roberta and Marco and myself, but I'm just a moderator. Thank you very much anyway. So the last question from Cristina. I'm interested in hyper-IgD syndrome, but as I understand, there are no evidence.
No, and this is the most tricky part of the story of the vaccine. I think you are alluding. I think that we have to do to test and to see, so far we do not have any evidence. I would say that it would be very important to make this a proper study on surveillance in this.
So very last question. We catch it because Leonardo was very kind to the speakers. Leonardo from Brazil. Some FMF using colchicine and canakinumab and one CAPS and Schnitzler syndrome, both on canakinumab, had COVID. The CAPS and Schnitzler had urticarial rash, fever, and high CRP levels.
You send me the picture, Leo. I remember. Can you intervene, Leo? Can you enter? Maybe Coralie.
Yes, if he can open the microphone, no problem.
Yes, Leo.
Leonardo, are you?
Leonardo. No mic today. So
okay, don't worry. Anyway, so I think we got around 30 questions, which is impressive. This is a clear demonstration of the interest that was raised by the speakers. So I wish to end this very interesting, very exciting talk and session by thanking very much and congratulating on behalf of all the audience, the two speakers, and Yvonne, excellent moderator as well. Thank you. Thank you very much, Yvonne.
Sorry, Angelo, just to remember that the next
okay, Marco,
will be on interferonopathies on January 28th, and will be given by Raffaella Goldman-Maschi. So remember, January 28th,
okay,
3:30 Central European time.
So I thank you very much to the audience on behalf of the two speakers for listening and for asking so many interesting questions. And Hala Lofty, she thanked great.